Assalamu alaikum. I'm Dr. Asad. I head Department of Community Medicine. Uh, Today we will discuss about epidemiology of cardiovascular diseases, and we will cover this topic through following learning objectives. Define cardiovascular diseases by understanding the definition of cardiovascular diseases, what it contains, by discussing the epidemiology of cardiovascular diseases. We will also identify the different public health interventions and approaches to control and prevent cardiovascular diseases and hypertension. What is the definition of cardiovascular diseases? Cardiovascular diseases is the name for the group of disorders of heart and blood vessels and include ischemic heart disease, hypertension, also known as high blood pressure, cerebrovascular disease, commonly known as a stroke, congenital heart disease, and rheumatic heart disease. Why cardiovascular disease is important? There are different reasons for that. One of the main reasons is that a substantial number of people, 422.7 million people, they are currently diagnosed or they are currently afflicted with cardiovascular diseases. The burden is huge. Like cardiovascular diseases are the number one cause of death globally. 17.9 million deaths from cardiovascular diseases in 2016. This is the latest figure that is available, and by this time it must have increased up to 18 million or something like that. And it represents 31% of all global deaths. We can imagine that out of 100, 30% is quite a substantial number. And of these 31%, 85% are due to heart attack and stroke. So within the cardiovascular disease dimension, heart attack and stroke are the major culprits. Over 3/4 of the cardiovascular deaths take place in low and middle income countries. Initially, it was thought that this is the disease of affluent people. This is the disease of developed countries. But now, due to the epidemiologic transition, there is a shift in the pattern of diseases. It's now becoming more common in developing countries. 25% of deaths are lost due to non-communicable diseases. 25% of deaths are the disability adjusted life years. We will discuss about it in detail when we come in the next classes, but till now it's easy to understand. There's a measure of burden. There are two types of measures: mortality and mortality and morbidity. But there is another thing which is in between these two, which is disability. So this is the measure of the disability. And now, what are the different types of cardiovascular diseases? Types of cardiovascular diseases, there's a whole list of cardiovascular diseases. Coronary heart disease, this is also known as the CHD, or ischemic heart disease, heart attack, myocardial infarction, or the angina pectoris. Cerebrovascular disease, stroke, transient ischemic attack, TIAs, hypertensive heart disease or hypertension, peripheral vascular disease, or intermittent claudication, heart failure, rheumatic heart disease, there's the post-streptococcal infection, congenital heart disease, and the cardiomyopathies. There's a whole list of these diseases, but what we are interested in knowing about are those diseases which have high burden. Those cardiovascular diseases which have high burden, like the ischemic heart disease, it's 46%. Cerebrovascular disease, 34%. Hypertensive heart disease or hypertension, that's the 6%. Inflammatory heart disease, 2%. So we are major concerned with ischemic heart disease, cerebrovascular disease, and the hypertensive heart disease. So how can we know that which areas or which people are more prone to heart diseases, heart problems? So the basic tool of research, or the basic tool of research, scientific research we have, is epidemiology. So And the cardiovascular epidemiology, like as you know, that the epidemiology, we divide epidemiology mainly into three: descriptive epidemiology, analytic epidemiology, and the experimental or interventional epidemiology. So descriptive epidemiology basically tells us about, it simply describes the person, the person, time, place, like how many people are affected, what's their gender, what's their ethnicity, at what time they are affected, in which year they are affected, in which season they are affected, and at what place they are affected, whether they are affected in a developed country or a developing country, whether affect, they are being affected more in an urban area as compared to the rural area, whether they are being affected more in some poor locality, poor neighborhood as compared to a financially sound neighborhood. And then there is the analytical epidemiology, which analytical epidemiology helps us in identifying the relationship between cardiovascular diseases and different risk factors. There are various studies, and we will discuss those in our upcoming slides, which tells us about the effect of different risk factors on different types of cardiovascular diseases. Third is the experimental epidemiology or interventions. It talks about the various strategies or various interventions applied to reduce the burden of cardiovascular diseases in different populations. So it helps us in identifying the types of preventive methods. So going a little bit more into the descriptive epidemiology, we see that the descriptive epidemiology mainly describes the distribution patterns in the world. Distribution pattern of what? Distribution pattern of cardiovascular diseases in the world, or any disease in the world. Globally, cardiovascular disease account for 1/3 of all deaths. It's nearly 50%. That's too large a number. Depending on the level of the economic development, as I have discussed earlier, that now it's becoming more a disease of less affluent countries or the developing countries. And among all the cardiovascular deaths, 50% are the coronary deaths. What is the distribution pattern? This cardiovascular disease is different in different aspects of, uh, it has different characteristics like geography, sex, age, ethnicity, socioeconomic status. Geography, as uh, it's commonly understood that it's the disease of developed countries. Now it's not so common. Now it's not so true. Sex, in which gender it is more common, whether it is more common in the females or whether it is more common in the males. Age, to cardiovascular disease affects people of young age group or the people of old age group more. Ethnicity, whether it affects the marginalized people more, or certain specific ethnicity people, people with certain ethnicity more. So, and as far as socioeconomic status, we have also covered about. We have also discussed that. Now, uh, looking at the why Pakistan, if you can have a look at, then the Pakistan is at the top with 423 millions, with 423 uh, number of 423 deaths per 100,000 individuals. 423 deaths per 100,000 individuals. And can anyone tell why Pakistan, Philippines, and Laos have highest cardiovascular death rates in Asia? Just think over it. And if you have a keen eye, you can identify, not just by a simple observation, that most of these countries are in the different stages of development, right? And they have different distribution of risk factors in them, different demographics, different distribution of risk factors, different availability of healthcare services. So the Pakistan is, unfortunately, is the one which is at the top. Now, taking each determinant one by one. Age. Adult lifestyle patterns usually start in childhood and youth. It's very common for the youngsters. They start smoking at the very young age, and if they start smoking at the very young age, they continue in adolescence. And once a smoker, it's very difficult for a person to quit smoking. And the dietary habits, most of the time the dietary habits, we have very bad dietary habits. The junk foods, the children and youth, the uh, most likely use the junk foods, and the lifestyle patterns that are set in the childhood, they are very difficult to change. And from the beginning of their life, the changes start to appear in their behavior, and that reflects in their health, in general health as well. As the age increases, the cardiovascular disease morbidity and mortality becomes maximum in 30 to 44 years of age and results in premature death. So it's a continuum. If you have a look at it, then the adult life, childhood and youth, from the childhood, the patterns, the smoking, the dietary habits, the sporting behavior, all these results in, if they are not being taken care of, they results in cardiovascular disease morbidity and mortality, which hits the 30 to 44 years prime age group, and the premature death, which is less than 64 years of age, or 25 to 64 years of age. It's below the 64 years of age. So that's very pity. That's a very pity scenario, and it also affects that's the main economically productive age group. 30 to 44 is the economically productive age group, and if uh, the person gets affected, if a chunk of and uh, Pakistan is having a substantial number of young people. So if these people, God forbid, if these people get sick with such chronic diseases, then the productivity, economic productivity of Pakistan would also be very low. So let's see the age group. If you have a look at that, you can see this is the proportion of mortality in different age groups, and it's about the men. And in 1 to 24 years, it's 4.6%. That's the mortality, and 32.7%, 25 to 64. And in more than 65 years, it's 55.8% in men, the mortality due to cardiovascular diseases. And so there's a steep rise from the young age to the old age. When we compare it to the females, we also see this is more or less the similar pattern. There's also a rise in the mortality rate group age-wise, from lower age groups to the higher age groups. Now, the sex. What's the common perception is? The common perception is that the cardiovascular disease is a disease of men. It is not a disease of women, and that the cardiovascular mortality is more common among men. However, when the women crosses her menopausal age group, then the risk becomes equal in men and the women. And women are more at risk. Women are more at risk after their after 60s, or after 40s or 45 years of age, because the two reasons. There's the higher prevalence of certain risk factors in women. This is the innate one. Diabetes mellitus, depression. The women are more likely to be depressed, and they're more likely to be anxious. They're more likely to be stressed, and the stressed releases the adrenaline, and this adrenaline in turn affects your blood vessels, and the whole there's a domino effect. And the gender specific risk factors, these are the risk factors only for the women: the oral contraceptives, hormone replacement therapy, polycystic ovary syndrome, because estrogen is said to be protective is protective for women, but before their menopause. So after menopause, there is no estrogen, and so they are become at equal risk as that of the men. Now, descriptive epidemiology in time of place and person, urban and rural. So the urban people, they are more at risk of being sick with cardiovascular diseases as well as compared to the rural areas. The reasons are clear. Urban people, urban life, they are getting accustomed to more mechanized, more westernized lifestyle, the more stressed lifestyle, unhealthy dietary habits, lack of physical activity, and smoking, tobacco use, and as compared to the rural population. And developed and developing countries, the distribution in the developed and the developing countries. In earlier stages, the developed countries were more at risk of uh, the people in developed countries were more at risk of developing cardiovascular diseases. But now this risk has been shifted, or is being shifted, to the developing countries. As in developed countries, they are taking more health conscious approaches. They are becoming more aware of the health uh, measures that can be taken. And the developing countries, they are now following those patterns which the developed countries are leaving behind. So we are seeing the similar patterns as we have seen in the Western countries. The time trends. The time trends basically tells about the time trends. The time trends are very important because they tell us about the pattern. The pattern, whether a certain set of diseases, they are increasing in number or decreasing in number, and what can be the different factors. What can be the different factors to control them? For example, giving an example of diabetes mellitus in Pakistan, that's the time trend, and it captures the 1995 time frame of 1995 to 2025. So here it is shown that in 1995, Pakistan was ranked eighth country with the highest number of persons with diabetes, and it is being projected that in 2025, Pakistan will move from 4.3 millions to 14.5 millions and will rank fourth in diabetes mellitus, in number of persons with diabetes. So that shift is quite alarming. I mean, we should take heat from them and try to. It will help us in devising the strategies to control or prevent the upsurge of diabetes. So now moving to the analytic epidemiology, as discussed earlier, that the analytic epidemiology tells us about the association between the different risk factors. In descriptive epidemiology describes the risk factors, analytic epidemiology describes the association of the risk factors with the diseases. There are hundreds of risk factors which are associated with coronary heart disease, hypertension, and stroke. And approximately 75% of CVD can be attributed to conventional risk factors. The conventional risk factors are the risk factors like high cholesterol levels, unhygienic diet, unhealthy diet, lack of physical activity, these factors. And the characteristic risk factors that are of great public health significance have following characteristics. They are highly prevalent in many populations like Eastern, Western, Caucasians, Asians. Great independent impact on cardiovascular. They are individual risk factors. They are independent risk factors. They do not need any other risk factor to cause the cardiovascular disease. However, if two or more risk factors are present, then there will be a synergistic effect, but they won't need uh, per se. Then the control and treatment results in substantial reduction in cardiovascular diseases. And another, that's a good thing, that identifying the risk factors and controlling them will result in a substantial reduction in heart problems. Risk factors, analytic epidemiology. Now, they're the developing countries. In developing countries, we have triple burden of disease: communicable, non-communicable, and the injuries. So, our efforts being are not focused enough to break the association between these factors, because we are going into three directions, at least in three directions. We are going in many directions, but at least we are also looking or also taking care of the communicable diseases, non-communicable diseases, and now the injuries also jumped in, right? So it's getting difficult, but it's essential to control cardiovascular diseases. Like the association between the risk factors and cardiovascular diseases. We conventionally divide these risk factors into major risk factors, or the major modifiable risk factors, and the non-modifiable risk factors, and also the novel risk factors, or the new risk factors. So the major modifiable risk factors are mainly the behavioral risk factors. We also call them as behavioral because they can be changed by altering the behavior. High blood pressure, abnormal blood lipids, tobacco use, physical inactivity, obesity. So high blood pressure is the independent risk factor for uh, cardiovascular diseases, and it can be easily. And the good thing is that it's very easy to control the high blood pressure by adopting the healthy lifestyles, increasing physical activity, by healthy eating. Like these abnormal blood lipids, they are also go hand in hand. I mean, uh, the, the risk factors, decreasing the risk factors have there's similar interventions or the similar approaches, like the healthy lifestyle, increased physical activity, relaxation, nutritionally sound, uh, maintaining a healthy body weight, not being obese. As uh, as per BMI, we call anyone who has more than 30 BMI as obese, and it has its own risks associated with uh, obesity. Unhealthy diet, diabetes mellitus. Diabetes mellitus makes this blood sticky, and then uh, the endothelial injury and all the stuff leading to atherosclerosis. Then there are the non-modifiable risk factors. These are the age. Age is obviously you can't change the age, and the hereditary or the family history. The people having the family history, to they are more likely to get cardiovascular diseases. And gender, males again. Other modifiable risk factors, these are all the low socioeconomic status, the person living in a poor neighborhood are more likely to develop cardiovascular diseases, because people have very low, these people have very low means of living healthy and good life, healthy and the prosperous life, uh, which can, which is health oriented. And then the psychosocial stress, heavy alcohol use, psychosocial stress, again it triggers the stress response, which is harmful to the vascular system. Heavy alcohol use, heavy alcohol use is really very uh, common risk factors in the Western societies, and now in the Western society, and the use of certain medications like hypercoagulants, the medications that can cause oral contraceptives, for example, oral contraceptives, or the hormone therapies, they can cause cardiovascular diseases. Lipoprotein A is again risk factors. There are novel risk factors. Excess homocysteine is an amino acid in the blood, and is associated with the cardiovascular problems. Inflammatory markers, C-reactive protein, blood coagulation levels, increased fibrinogen levels. So the whole spectrum comprises of the modifiable and not non-modifiable risk factors. Obviously, we need to work on the modifiable risk factors, and they provide a great dividend. By investing a little, we can reap much more. The burden of tobacco deaths, how much death the tobacco caused. There is data from the annual tobacco death atlas in millions. It compares 2000 with the projection in year 2030. It shows that in 2000, the developed and developing countries, the annual tobacco deaths were 2 million in both, but it's projected that in the year 2030 that there will be an increase of only 1 million in developed countries in tobacco deaths, whereas there will be an increase of 5 million in tobacco deaths, in annual tobacco deaths in developing countries. So, and these tobacco deaths will cause deaths in the middle age people, mainly 35 to 69 years of age, which are uh, 35 to 69, the early part of the 35 to 50. It's a economically productive age group, and half a billion people now alive will be killed by tobacco products, and half of the deaths will happen prematurely. So we can see that how the tobacco deaths is shifting from the developed to the developing countries. Diabetes. So if you have a look at there are the different continents. These are the WHO regional estimates from 2000 to 2025 in adults aged 20 years and above. So from Africa to the Southeast Asia. So the major rise is seen in Southeast Asia. The people living in Southeast Asia will brunt the burden of diabetes. It's said that the people in Pakistan and India, basically the Indian subcontinent, they have they are genetically predisposed towards getting hyperglycemic states, and thus having diabetes related issues. Now, what about the prevention? If you want to prevent these, there are different type levels of prevention that we have discussed, and we discussed that there are different types: primordial prevention, primary, secondary, and the tertiary. Primordial prevention is basically preventing the risk factors uh, from coming up, right? Uh, for example, it includes the social, legal, and other measures, activities which may lead to lowering of the risk factors. जी आप उस risk factor ही को ना होने दें, right? Like smoke-free restaurants. If you have a smoke-free restaurant, you won't be exposed to smoke, and hence you are curbing that risk factor from occurring, right? Primary. Primary is mainly, as we know, is about the health promotion and specific protection. And when we talk of health promotion, it's like the health education programs. It's about blood measuring blood pressure, regular measure of blood pressure, anti-smoking campaigns, and like these. It's about the health promotion and specific protection. Secondary is early diagnosis and treatment, and that includes the screening of and treatment of symptomatic patients, set up personal risk profiles, individual risk profile like these, and the cardiovascular rehabilitation. Tertiary is mainly about the rehabilitation. So rehabilitation includes maybe the CABG or we also call it as the coronary artery bypass grafting or implantation, and things like that. Besides these four, primordial, primary, secondary, and tertiary preventions, there is other uh, school of thoughts. We have divided high risk approach and the population approach. The high risk approach or individual approach talks about detecting those people at the greatest risk. And who can be at the greatest risk? People who are who have following risk factors, or the different risk factors, like obese people, people with high cholesterol levels, people with a family history of cardiovascular diseases, males, middle-aged males, hypertensive people. These are few of the examples. And the smokers, these are sedentary people having sedentary lifestyle. So these are the greatest, these people in high risk approach or the individual approach, you have to identify the people or the person with the highest risk and give lifestyle guidelines. Basically, these are the behavioral risk factors. Most of the risk factors that can be changed are the behavioral risk factors, and they can be changed through the behavioral intervention, right? And then there is the population approach. Population approach considers the whole population. It says that includes the high risk plus the low risk, both type of individuals, and it provides coverage for both of them. And what it entails uh, different programs, different interventions. Like, for example, uh, in one of the study, it was uh, planned to give low salt diet to one community and the normal diet to another community, and it was observed that the low salt diet, the community having low salt diet has a lower blood pressure than the people having the normal or the high salt diet. So it applies its intervention to the whole population levels. Below are few of the examples from the research projects: Framingham Heart Study, North Karelia Project, Finland, Stanford Projects, USA, Minnesota Cardiovascular Health Program, US, Multiple Risk Factor Intervention Trial, Mr. Fit. So all these trials, few of these trials are still going on. But the beauty is that through these projects, we came to know about the different risk factors, the novel risk factors, as well as the different approaches, different interventions that helped in reducing cardiovascular diseases at the population level. Now, let's have a summary slide. And the beauty is that the population approach is the most cost effective one. Making up, for example, decreasing 5 millimeter mercury blood pressure level at a population level have much more beneficial effect than having this decrease in at the individual levels. Now, coming to the summary slide, let's say it's a summary slide of how the cardiovascular disease develops. So you see that there are two main areas: the genetic polymorphism and the diet and the exercise and the lifestyle. These are few of the things, not all. And below there, you can see that the interaction of diet, exercise, smoking, stress, other environmental factors, and other environmental factors may be heavy metals in water, maybe particulate matter in air pollution, and the other genes, they combine with the person's uh, different types of lipid, lipids in the human body, and and then uh, this genetic polymorphism is that, and then this genetic polymorphism along with the environmental risk factors results in cardiovascular diseases. So that's now. If you have any questions, you can email me at asad.adi@frpmc.edu.pk. Thank you so much. Thank you.